Welcome everyone. Oh, it's 12:30. We'll go ahead and get started. So glad all of you could join today. Welcome to Project Echo Geriatrics. I'm Kate Bennett. I'm the medical director for Project Echo, and I'm just really glad you could all join us. July is an exciting time. There are a lot of transitions happening, new residents, people moving up to the next year residency, new chief residents, folks moving to their next year of school, some people taking summer breaks, most people not taking summer breaks, some people's children on summer break, which disrupts our days a little bit, but is also wonderful. So anyway, however July is treating you, I'm glad you joined us here today. We're going to start off, as we always do, with a new academic year with an intro to Project Echo. Why are we doing this? What is this all about? And age-friendly care, to give some context for what that is for those of you who haven't heard that already. And then we'll go into a case, and we have a really fantastic superstar medical student who has been kind enough to present a case from her clinical work. So we'll get into that after the didactic. I will go ahead and share my screen if I could get it to work. That's always the thing. Let me try. It's going to take me a moment here to get it all set up. You'll hear my clicking. Great. I think this is going to work. It's going to work. All right. Did it work? Yay. All right. Thanks, everyone. Okay. So I'm going to talk about Project Echo and age-friendly care. And for those of you who have been attending Echo for multiple years, you will have heard much of this already, although I update it every year with the latest. All right. We'll talk about the context of Echo. I'll describe what we mean by age-friendly care, and then we'll talk about some of the nuts and bolts of Echo participation, since I'm hoping you'll all join us for the year. All right, so what does Echo stand for? Why do I keep saying that? Echo stands for the Extension for Community Health Outcomes, and this model was developed by Dr. Sanjeev Arora, who was a hepatologist at the University of New Mexico. He just recently retired, and he decided that since there were patients very far away from the academic center, just one academic medical center in New Mexico, and back then the treatment for hepatitis C was quite complex and toxic, and people were not getting the care that they needed, or were having to travel many hours to get to the academic center. So his idea was, why don't we train primary care providers to provide this care right in their own clinic? And we're going to do it by a webinar, basically Zoom. We're going to have monthly sessions, and we're going to teach people the basics of how to treat people with hepatitis C and run through cases. So it's this telementoring model. It's this way to provide education to primary care teams in order to make sure that folks can receive care right where they are. And it was highly successful. Treatment outcomes were the same, if not a little bit better, by the patients who are treated by their primary care providers as opposed to going to the academic center. And they were able to reach patients who otherwise were not getting care, and to reduce health disparities. This ECHO model, being highly successful, just spread across the world, and now over 7.7 million people have attended ECHOs. And it is being used for a wide range of subject areas, not just hepatitis C, but geriatrics and HIV care and diabetes and heart failure, as a way to, throughout the world, make sure that we can move knowledge and not people, is what the Project Echo folks say. So why Project Echo Geriatrics? Well, we all know that there are more and more older adults every day, and the projections are that we will have even more older adults that we're caring for wherever we're practicing. But despite that, there aren't a lot of geriatricians like me and Ru Wang and others who are on this call, there are fewer than 7,000, like getting closer to 6,500 geriatricians in the United States. So it's really all of the other primary care providers who are providing most of the care to older adults. And we really need to make sure that everyone knows these principles of high quality care of older adults. So we launched Project ECHO to solve this problem back in January of 2016 as part of our Northwest Geriatrics Workforce Enhancement Center, which is a center that trains the workforce in the Pacific Northwest to provide high quality, age-friendly care to older adults through a variety of initiatives, and this is just one of them. And we've been running these sessions year-round, every month, third Friday of the month from 12:30 to 1:30 every month since 2016. And some of the participants on here have been here every month, and some people have come and gone. But we always do the same thing. We do a short didactic that we put on our website. We have a YouTube channel for the didactic. And then we also have some time for discussion. And the heart of ECHO is case consultation. So every month, someone plans in advance. I'm not going to just call in someone. Someone plans in advance to present a case. And it doesn't have to be anything fancy, just an older adult that you're caring for, so that our interprofessional panel and all of you can think together about how to improve the care for a patient, particularly one where you have some questions. So I'll give you a little bit of framework why age-friendly care is important. I'll tell you a story of a patient that I came across in clinical practice who really stuck with me. A 90-year-old woman who had 6 years of progressive forgetfulness, but no diagnosis of anything formal. Didn't have a dementia diagnosis, although it was clear that she had it. She had hypertension. She'd been falling a little bit recently. She lives with her daughter, though she has 12 other children, and does not have a durable power of attorney or surrogate decision maker designated. And she was admitted to the hospital for cellulitis. Should have been a pretty straightforward thing, but during her admission, because of her dementia, she was getting up when people weren't necessarily planning for her to, so they restrained her. They didn't mobilize her at all. She just spent most of her time in bed and got weaker and weaker and went from ambulating to needing a lift to get up out of bed. And because of this, she ended up very deconditioned. She also was delirious during the hospital stay, which is not uncommon for people with dementia. And she received some medications like lorazepam that made her delirium much worse. And it just escalated the use of restraints and escalated her immobility. So this woman ended up really deconditioned, very confused, way below her baseline, largely due to the way that hospitals tend to take care of older adults who have cognitive impairment or who have delirium. And so she ended up discharging from the hospital home. The team wanted to send her to a nursing home, but her family very clearly said, like, she never wants to be in a nursing home. So they brought her home, ordered home health. Her daughter took care of her. They discharged her on the same blood pressure meds she was on in the hospital, and her blood pressure was really low because she didn't need that much of her blood pressure medication anymore. And she ended up with pressure ulcers. She ended up, when she left the hospital, she was basically nonverbal, even though she was very talkative before the hospital, bedbound, and she ended up dying of a cardiac arrest and having active CPR and dying in an emergency room shortly after discharge. And this just really, displayed to me the opposite of age-friendly care. And unfortunately, this is not uncommon. And this is quite common in our healthcare system for this sort of preventable complications of hospitalizations to happen. So just some examples of the state of care in our country. Over 30% of older adults are prescribed potentially inappropriate medications every year, meds that might contribute to falls or cognitive impairment, for example. Falls lead to over 3 million injuries that are treated in our ERs annually and lead to over 1 million hospitalizations. And this is despite the fact that we know that falls are largely preventable through evidence-based practices. Only 50% of those with dementia are diagnosed with it. So there's no way to provide evidence-based care for someone if you don't even make the diagnosis. And certainly when someone's moving through the healthcare system, if we don't know that someone has dementia, we can't really make sure that care is tailored to someone's level of cognitive impairment. And finally, this is all happening not because older adults aren't seeing healthcare providers. Older adults on average in this country spend 21 contact days per year engaged in healthcare. These are days that they go to a clinic or a therapy appointment or have a procedure. 21 days throughout the year they're spending doing this. So it's not the quantity of the care, it's what we're doing when we're taking care of folks. So because of this, the age-friendly health systems movement was launched by the Institute for Healthcare Improvement, the John A. Hartford Foundation, the American Hospital Association, and the Catholic Health Association of the United States. And they started working on this back in 2017. So what do I mean by age-friendly care? Age-friendly care follows an essential set of evidence-based practices, the kind of this guide for how to take care of older adults, the 4 M's that I'll talk about in a moment. It causes no harm, and most importantly, it aligns with what matters to the older adult and their family caregivers. So these 4 M's of age-friendly care, which are based in the evidence of what we know is going to lead to best outcomes for older adults and the highest quality care and patient satisfaction, as well as reducing costs all at the same time. The 4 M's are what matters, medication, mentation, and mobility. So what is meant by each of these? So what matters is really knowing and aligning care with an older adult's health outcome goals and care preferences. So what matters most to someone? Just asking them what's most important to them. And this isn't just for end-of-life care. This is for everyone that we take care of in every setting. Knowing what matters to someone makes a big difference in how we arrange their care. For example, if someone is trying to avoid falling, well, we'll err on the side of trying to avoid falling with things that we prescribe. Or if they want to spend time walking their dog, we're going to really focus in on their mobility so they can do the things they need to do to be able to do that, or spending time with their grandchildren. Knowing these sorts of things is so important to the care, because if we're just working toward our goals without asking someone what they care about, then we're going to make a treatment plan that really doesn't matter to the patient. Finally, not finally, the next one is medications. So if a medication is necessary, and oftentimes it's not, we can use non-pharmacologic options for a lot of things, but when it is, we want to make sure those medications aren't interfering with what matters to someone, with their mobility and their mentation. For mentation, we're really thinking about preventing, identifying, treating, and managing dementia, depression, and delirium across all settings of care. And mobility is ensuring that older adults move every day to maintain their function and do what matters. I gave that example of the woman in the hospital who was not mobilized at all during her stay. It leads to a lot of hospital-associated disability. In the outpatient setting, making sure we're preventing falls and keeping people moving is very important. So when you implement these 4 M's, it's important to think about a few things. So they're a framework, and they're meant to be implemented together and reliably, meaning you don't just pick an M that you like and do that for your patients. Really, all older adults should have all 4 M's done. You won't necessarily do that in every visit all at once, but making sure you're addressing that for all of your patients over time is really important, and you do that with your team. And reliably means that every older adult gets this. And it can be implemented across an entire healthcare system. There are healthcare systems, some of yours that are on here, that have implemented the 4 M's across the whole thing. So no matter where everyone is, these are assessed and acted upon. But you could also do it yourself. You could just walk around with those 4Ms in your head and do that in a clinical encounter and make a huge difference. They need to be incorporated in what you're already doing. So you don't just provide primary care or hospital care and then do that 4Ms thing. It should be baked into what you're doing and into the systems that you have. And finally, the tools that you use to implement the 4Ms can vary. There's no one particular falls screener or delirium screener or anything of that sort that you have to use, as long as it's based in the evidence. There are a lot of tools on the Institute for Healthcare Improvement website that can give you examples of what you can use to implement the 4Ms, the different screening tools and different follow-up plans. But you just have to do what's based in the evidence and works for you. It's very flexible. Over 7,000 hospitals and practices as of this month have adopted age-friendly care and have shown that they're consistently providing this across their older adult patients. So it's definitely growing. When I first gave this talk many years ago, there were just a few hundred, and over the course of about 5 years, it's grown to over 7,000. Well, how are these operationalized? So for each of the 4Ms, what matters, medication, mentation, and mobility, they have to be both assessed and acted upon. So for example, it doesn't help to screen for falls or cognitive impairment if you don't act upon what you're doing when you find that. So anytime you are addressing the 4Ms, it's important to think about the assessment and the action. There are a bunch of tools on the Institute for Healthcare Improvement website to make this easier for you. If you're not sure about one of the areas or you want to change something about what you're doing in your clinical setting, they have a bunch of tools to use so you don't have to figure it out yourself or look to the literature yourself. So what if that lady I talked about at the beginning had age-friendly care? She's the woman who had dementia that went undiagnosed and was admitted to the hospital, developing delirium that was worsened by medications that made it worse and restraints and not mobilized, and ended up dying shortly after being in the hospital. What if she had age-friendly care? What would that look like? So she would have, if she were in a health system that implemented the 4M, she would have had her cognition screened and would have been diagnosed with Alzheimer's disease many years ago, and would have had an opportunity at that point to also discuss what matters, which is time with family. And she selected one daughter as her healthcare proxy instead of having 13 children decide together what decisions were to be made. For her mobility, she had a fall screen and was referred to an exercise program and educated on home safety to reduce her risk of falls. She had high-risk medications deprescribed to optimize her cognition. And when she was admitted to the hospital for cellulitis, they reviewed what matters and confirmed that it was being at home with family, so they moved toward that. They knew that she had cognitive impairment, that she had dementia, and they implemented delirium prevention protocols and kept her mobilized so that she wasn't immobile when she left the hospital. And they kept her moving so that she was able to use a walker at home instead of being bedbound. And as her dementia reached its final stages, her daughter enrolled her in hospice, and she was able to spend her last days at home with her family. So this is what we're trying to achieve. There are big impacts you can make by implementing age-friendly care on the quality of life for older adults. And there's so much that we can avoid in the way the healthcare system is set up right now to help people live better. The Center for Medicare and Medicaid Services has made age-friendly care required for hospitals, for most hospitals with few exceptions. And it's starting next year. There will be some payment penalties to hospitals that aren't working toward age-friendly care and attesting to their age-friendly care. And you'll also be able to look at CMS Care Compare and see whether or not a hospital is implementing age-friendly measures. That's a whole talk in itself, what's included in those measures, but just know that there's a little bit more of a push to make this happen for everyone. So thank you for joining us for Project Echo. For those of you who haven't participated before, this is very interprofessional discussion. We have geriatric specialist panelists from a variety of health professions, and I'll list our panelists in a moment. But it takes an interprofessional team to provide excellent age-friendly care. And so no one on this call should feel like they're doing this themselves. It's always done as part of a team. We encourage you to present cases. It could be any sort of scenario that you are managing in a clinical setting. We like to focus on primary care, but it doesn't have to be primary care focused. Anyone can present from your team. Any member of the interprofessional team can present. Students can present, as you will see today. It's okay to leave sections blank on the form. It's long and it's meant as a teaching tool. You have to de-identify all of the patient information. Everything we do is de-identified. And we ask if you're submitting a case that you do it at least a couple days before the session. We would like the residency sites participating to present at least one case sometime in this academic year. So please reach out to us about that if you haven't signed up already. And you can send an email to northwestgwec@uw.edu to get the case form, or we'll send it out also each month with our reminders. A few additional tips for participating and getting the most out of this. If you can put your video on, it's so much better for community building. I do understand that sometimes that's not possible, but when it is, please do. And please invite your team, invite trainees you're working with, invite interprofessional team members, because all are welcome, and everyone who participates just enriches the session. This is an all teach, all learn situation with Echo. So I encourage you to chime in with input on the case discussions. I've learned a lot more from the participants throughout the region than I have from almost anything else throughout the last 9 years that we've been doing Echo. And I also learn about your settings, because everyone has different resources in their clinical settings, and it's important for you to share that. It makes us all better. So we're going to work together to make healthcare more age-friendly, and I thank you for taking the time out of your busy days to participate. You can always reach out to me. My email's there, bennett4@uw.edu, with geriatrics related questions or echo related questions. I'm always happy to help.